It's a bit weird trying to do everything online, but oh, there's Alex. Excellent, Alex has joined as well. I'm Doris Jimson, the committee. I joined the governing body May, I think, sometime in May. So this is the first meeting. Can I just remind everybody that because this is a public session, the session is going to be recorded and put on the website afterwards. And I would also ask if we could resist from using the chat function, because anything on there will also be on the website afterwards. So if anybody got any questions, if you could just raise your hands and I'll try and catch you on this grid. And if I really can't see you, do shout at me, but let's try and work it that way. If you're not speaking, please mute your mics so that hopefully there's less interference and the recording is of slightly better quality, and maybe technology might not fall down as quickly as well. And the other thing is just to remind everybody about declarations of interests. We hadn't put it on the agenda, but it's a standard item. And if anybody's got any interest in to declare that's not already notified, this is your chance. So if I don't see any hands up, I will assume there's nothing additional to declare. Everybody's sitting on their hands. Oh, Alex, hi.
Hi. Oh, hang on. Let me. Am I unmuted?
Yes, you are.
Yeah, I just need to declare that I'm the chair of the Diabetes Clinical Senate.
Thank you. I did send round about half an hour ago to, you might not have picked it up, just a heads up in terms of, as this is the first committee meeting, if I'm just going to go around and ask for a brief introduction. And if you have any thoughts about your hopes, goals on how the committee should work, this is your chance. I'm not proposing to comment on any of your thoughts. There is no right or wrong thoughts. And then we will, Sadie and I will kind of collate your thoughts and reflect back probably in July when we've had a bit of time. I just felt that it would be good just that if we could all be vaguely on the same sheet to start with, so that people are not disappointed. As I said, I'm Doris. I was previously on the North Norfolk CCG as chair of audit committee, so this is a slightly different role for me, and I'm looking forward to the challenges. I'm going to keep my thoughts about the goals and challenges to myself for now, and everybody's smiling. I'll start with Hein because he's the next one down.
Thank you, Doris. I'm Hein van der Willenburg, previously involved with South Norfolk CCG, as chair of the Finance and Performance Committee, and actually also the chair of the Primary Care Commissioning Committee, where we had meetings in common with North Norfolk. So I've had some previous experience with primary care commissioning committees. Some of my thoughts, the obvious ones is meeting the requirements that go with delegated commissioning, and the terms of reference Article 14 gives a long list of what that entails. But I think more specific, maybe a good umbrella is what I would call the delivery of the primary care strategy, which was approved by the 5 CCGs a little while back. And many things fall under that, in my book at least. So patient experience, performance, both non-financial and financial. I think PCNs would be a good anchor, and I felt the terms of reference were fairly light on it. So how is it progressing? What are the challenges? What are success stories? recruitment, workforce, technology enablement, estates, you name it. And maybe a plea, and I know I made this point to both Doris and Parveen on an earlier occasion, but even with a year chairing the primary care commissioning, I find myself struggling with some of the terms and concepts still. So to get to this one song sheet to sing from, it would help if maybe we do something on development in terms of understanding key concepts a bit better. I think that would do the committee some good. I'll leave it at that, Doris.
Thanks, fine. Kathy?
Hi everyone, I'm Kathy Branson. I am the independent registered nurse on the governing body. Prior to that, I was briefly on North and South, and then prior to that, I worked at Health Education East of England, being the nurse lead there and also the head of workforce development. In terms of this meeting, absolutely echo what Hein says in terms of the strategy. Very interested in how the new architecture will deliver more integrated services. I'm particularly interested in quality, and I don't struggle necessarily with the terminology. I struggle with some of the papers because I don't understand what it means from a patient's perspective. You know, if you present me with some relative costs, they don't really mean as much to me as understanding what the clinical outcomes might be. And also the other thing that is sometimes absent for me is how are the new arrangements and how will we commission services that address health inequalities and support health improvement. So those are the things that interest me. I haven't exactly answered your question, Doris, but I don't apologise for that, sorry.
You have free vague. I don't want to be prescriptive on this one. Who shall I finger next? Oh, Tracy, you're sitting above.
Okay, I'm next on the list. So I'm Tracy Williams. I'm one of the elected clinicians on the governing body. I'm an advanced nurse practitioner working in primary care in Norwich, and formerly I was the chair of Norwich CCG. So with outstanding kind of the statutory functions of this committee, which we know is delegated commissioning and all that entails, in respect of that commissioning and management of primary care in our system, for me, it's about the future, it's about the primary care strategy, it's about moving on post-COVID, what that means for primary care and how this committee supports that. It's about us becoming an integrated care system and what that means for primary care as a provider within that, particularly those primary care networks and the opportunities. So like Kathy, I have a huge interest in tackling inequalities and prevention and kind of what primary care can do in that regard in the future in respect of population health management. So with all of the statutory part of it, there's the development, the strategic direction, and what it means for primary care in the future. So I think in respect of my role on this committee, I'm not a voting member as such. I'm here really from my experience and my kind of what I can bring about knowing about primary care and its current climate at the moment. And I'm also very keen that primary care is different across Norfolk and Waveney. We have 5 very different localities, and I'm very keen that we don't lose that in what we're doing, which I hope we won't with our primary care networks.
Thanks, Tracy. Kath?
Hello, I'm Kath Byford, and I'm the Chief Nurse for Norfolk and Waveney. I won't repeat some of the things that Kathy and Tracy have said, but I think what I'd like in terms of this committee going forward, we need to find a rhythm, particularly between this and the Quality and Performance Committee in relation to primary care quality and how we work the most effectively to make sure that it's either not duplicated or omitted in terms of that level of oversight for quality within primary care. We have 105 practices. I do recognise what Tracy said about not wanting to lose some of the benefits that we've had by doing things differently, but we don't have to do the same, but we need to have some equity in terms of access to primary care for our population, albeit differently delivered in some cases, and we need to explore unwarranted variation and patient feedback, patient satisfaction, and really embrace the new ways of delivering primary care going forward with use of technology, and hopefully making a big difference to people being able to access primary care through the different ways of doing so now, and having a much better impact on experience, such that the urgent and emergency care system isn't the default position, as I think that's where we were going. And also finally, we're asking more and more of primary care going forward. Particularly, we've learned so much with COVID. We need to take as much away from acute hospitals where it doesn't need to be done. So therefore, we need fair and appropriate ways of commissioning services so that primary care have a good chance of actually being able to deliver services in a way that's much more close to patients than having to traipse off to an acute hospital all of the time. I'll stop there now.
Thanks, Kath. Emma.
Thank you, Chair. So I'm Emma Queen Morris. I'm the Associate Director of Finance. I'm here today deputising for John, who's extended his apologies. Joined West Norfolk in the inception in 2013. I think from a finance point of view, hearing already what's been said, what's really important is finance to be integrated. I need to make sure I can help support you make financial decisions, make sure that what we're spending our money on is value for money. Importantly, coming to Kathy's earlier point, making sure that what we're presenting to you is clear and understood. But part of my role, I think, is to help you make those informed decisions, highlight any risks and help find any mitigations. So I hope that some of the papers we introduced in the last 12 months are things that we can carry on from the good work, but certainly I'm open to any changes to make sure that what you're being presented with going forward is something that's of value to you.
Thank you. Parveen.
Sorry, I'm having problems with my mute button today. I'm Parveen Mercer, Head of Delegated Commissioning, and I used to be the Associate Director for Delegated Commissioning, so I've had the privilege of attending all 5 PCCs across the old CCGs. I won't echo, like Kath said, what everybody else has said, but I think some of the challenge is going to be is how we get through all of the core business in one meeting, condensed down from what used to be 5 quite heavy agendas. And I know Doris and Sadie and I have had conversations about how we sort of space out some of the quarterly reports that need to come to Primary Care Commissioning Committee, but the challenge is going to be is how do we work together as a committee to try and get through what will be quite a busy agenda over the next year.
Thanks. John?
Afternoon, everybody. I'm John Webster. I'm the Director of Strategic Commissioning for the CCG. Prior to that, I was the Accountable Officer for West Norfolk CCG, where I joined in 2017. I've got commissioning background in Hertfordshire, Bedfordshire, Luton, Milton Keynes as well, so I've been around the patch a bit. I'm happy to stay stable for a little while in Norfolk. So I'd echo much of what's gone before, Doris, I think, and obviously I've got a particular interest in thinking about how we implement the primary care strategy effectively across the patch. I'd echo certainly the points around how we ensure a thread running through some of the committees we've got, and very much how they integrate with one another around some of the assurance that we're seeking as a CCG, as a committee of the CCG. And without sounding too officer-like about it, I think the assurance function is particularly important, linked to the delegated budgets and how those are applied. And I just hope that during the course of the committee running, we can have some good debate in relation to what we're looking to spend our money on. And a sense of collective decision making is what I'd like to see, so that actually we're reaching decisions together as a group of individuals from quite different areas, and NHS England as well, and different directorates within the CCG. So very much looking forward to it. Thank you.
Thank you very much. Alex.
Sorry, can you hear me now? I'd echo what everyone else has said. I suppose the one thing I'm very keen on is to actually sort of try and see as far as possible complete transparency and far greater patient engagement and involvement. I think we've seen some very good results recently, thanks to both Kath and Michael, in certain areas, and I mean, people now think that they're demigods. But I think we're constantly missing out on a trick, and I think with the advent of COVID, we need to really capitalize on the changes that have happened as a result of it, and actually make hay whilst the sun is shining. You know, deep tragedy, but a lot of good changes that have happened very, very quickly need to be expanded upon. But I think we also need to show demonstrable strategic links into social care within all of this.
Thanks, Alex. Kerry?
Hello there. First time knowing about this, so I'm just trying to get my head around everything. Andy, my CEO, is just gave some input, just saying about you know, obviously the terms of reference would be adhered to, and we would challenge should ever the need arise as a health watch. So obviously our particular interests, as Alex has said, around engagement. So ensuring we try and bring patients with the journey, because obviously we've seen a lot of changing in primary care due to COVID, and some of that was kind of enforced, I suppose, but was inevitable. It just happened a lot quicker. So my experience in community development is that you know, patients want to know the why behind things, and I think as a committee, being able to ensure that engagement has correctly taken place and consultation to bring patients with us, and then that's a win-win situation all round, really.
Brilliant, thank you very much. Fiona?
Thank you. I'm Fiona Thiedham, the Senior Contract Manager with NHS England and Improvement, and I'm responsible for working with the Norfolk and Waveney CCG system. I think from my perspective, you won't be surprised that I come from a more of assurance role, but assurance with support, which is very much the approach that we're taking with all our systems at the moment. I think the challenges that we're seeing, the challenges that primary care are going to face during the coming year are going to be quite different from where they were 3 months ago, 4 months ago. And so I think from our perspective, you know, what we're looking for from the committee is obviously that decisions are being made in a transparent, equitable way. Thinking about, you know, obviously in line with the regulations and policy, but picking up on a lot of what other people have said about thinking about health inequalities, consistent approach, and that sort of thing. So my role, I guess, is really to ensure that the committee is following the appropriate guidance and offering the support that we can.
Thank you very much. Michael?
Hi Doris, yeah, I'm Michael Dennis. I'm Head of Medicines Optimisation for Norfolk and Waveney CCG. Formerly I was Great Yarmouth and Waveney CCG, and I've been working for visiting the Primary Care Commissioning Committee for GYW and some of the other committees, so I've got some experience of doing that. Usually my job to give a brief update on how the area benchmarks on prescribing performance in terms of finance and quality against national and regional indicators, spotting inequalities, sharing plans and updating the committee on how we're doing in a fairly brief format that's relevant to be shared in public, bearing in mind we have these crossover with other committees, quality, performance and finance. But it's a very useful forum to hear from, formally talk to Health Watch, etc., although we do talk to each other outside, and to talk to the LMC, get our plans in terms of prescribing quality schemes approved for finance, etc., and discussed with the LMC in a sort of contractual fora. And I'd be interested to know what the committee, how much depth the committee wants in terms of detail in terms of the wider area in terms of performance. So I'll perhaps have some offline discussions with perhaps Doris and Sadie about what a suitable report might look like and what sort of level of detail you might want shared, because medicines is a big spend and a big area of quality concern at times. So it's important that we keep an eye on it in a formal manner, and it's the most common intervention in the whole of the NHS is to prescribe a medicine. So it's important that we focus on it on a regular basis.
That's great, thank you. Mark?
Good afternoon. And the panic sets in when you realise you've got to think of something else new that no one else has said. But I'm Mark Burgess. I'm Locality Director for North Norwich and South Norfolk localities. But actually, as a part of the COVID-19 response, have been the Senior Responsible Officer for primary care and our response to support primary care, hence here today. Some of what I'm about to say has been touched on by others, but I'm keen to just kind of stress three areas. Number one, Tracy's point about that, how do we make sure that we do, as a committee, what we can do once for primary care rather than 5 times? Absolutely. But as a locality director, how do we make sure that we're absolutely meeting the needs of primary care and communities in each of those areas, and make sure that we get the balance right for that? Secondly, building on what Alex said earlier around the changes that have been made. I remember at the early onset of the COVID-19 response saying that I felt we delivered 3 to 5 years worth of transformation in 3 to 5 weeks. How do we maintain that really good, positive, making change for patients? And linked to that, really, Kathy's point about integration. Primary care today is almost unrecognisable to where it was 6 months ago. And a lot of that has been very positive. I think we're getting the integration agenda. How does primary care and how do we work with community, secondary care and social care more, and really embed primary care in that? So I'm afraid it's a bit of a repeat for others, but I think they're really key and important ones.
Thank you. Last but not least, Sadie. I've given you the poison chalice to wrap this one. I'm sorry, I should have warned you at the beginning.
Could be very short from me, given everybody else. Hello, my name's Sadie Parker. I'm the Associate Director of Primary Care for Norfolk and Waveney, and delegated commissioning falls within my portfolio of responsibilities. I absolutely echo what everybody else has said, and I look forward to developing proposals with Doris for you to look at in the July meeting. I think building on what everybody else has said, having a single primary care committee allows us to offer consistently to all patients across Norfolk and Waveney, albeit that will be sensitive to each of the localities. We can make sure that whether you live in one part or another part of our area, that you have access to the same high quality, consistent general practice. And I think that's going to be a real benefit of our new committee. And obviously, completely echo what everybody else has said around the primary care strategy implementation and primary care networks and so on.
Brilliant, thank you very much. I'm sorry this has taken a bit more time than it's on the agenda, but hopefully it's helped everybody to get to know everybody else a wee bit in a virtual world. On to apologies we've got from Joningham and Mel Bentle from LMC. I think those are the only two. On the third item on the agenda was the terms of reference. We put it on really just for the committee to note, because the terms of reference of the committee is actually part of the constitution of the CCG, which was approved by the governing body at its first meeting in the 1st of April. We did have some comments back from Mel, who I think was circulated to everybody pre-meeting last night. The some of the comments, I think we will certainly take it into account when we come to review the terms of reference at the end of, towards the end of our first year of operation, because I think sometimes you just need to run the committee for a bit to see whether it works and whether anything needs tweaking or not. But I just want to note that actually the LMC was consulted as part of the constitution development. So the comments that came last night are new to all the officers. I think both Hein and I sat on the Constitution Working Group as well, and that never came across our radar either, the comments they're making. But, you know, we take those on board, and we will review them at the year end with any other practices that we feel that needs changing. I don't propose to say anything more unless anybody's got a burning issue they want to raise or question at this point. Great, thank you. On to the fourth item, Chair's action. I was asked to take a Chair's action, which is in your papers, in terms of recruiting for Norwich PCN. The papers are in the pack for you to note, and the background paper that I looked at as part of the approval process. And again, if anybody has burning questions, here's your chance. But excellent. On to item 5, which is the interpretation and translation service. A new paper was circulated this afternoon, and I think that will be the paper that we will be looking at, because then the details can be published on our website. Can I pass on over to Fiona to just give us a summary and edited highlights?
Yeah, hi. Thank you. Yes, apologies for the paper being circulated. All we've done is remove the value of the Arden and Gem proposal for engagement on paper that was circulated this afternoon. So there's no other changes in it. I'll take the paper as read, but the commissioning paper is to request approval to start a patient and stakeholder engagement exercise and to obtain, I suppose, CCG agreement in principle at this stage, that they might like to participate in this an East-wide approach to interpreting services. So at the moment, across the East of England region, there are multiple arrangements in place. And what we'd like to do is to try and put some consistency into new contract and make it give patients and contractors a fair and equitable access to services. In Norfolk and Waveney, a new contract was put in place last April, and that was for 2 years, and that expires next March, hence the reason we're starting this process. It would be fair to say that since I wrote the paper 3 weeks ago, 2 or 3 weeks ago, our thinking has moved on quite a long way. You will see within the paper that the time frame is very tight. And this links back to a new contract having to be in place by next April. Over the past couple of weeks, our understanding of what needs to happen and how we approach, particularly the patient engagement part, it is complex. And as you can imagine, in the current environment, having to do everything via technology is going to be a challenge. So we think that it's likely we will be looking to ask for a contract extension. Learning from our past experience of when we put the new contract in place, we know how important patient and stakeholder engagement process actually is. So we need to make sure it's right. We need to make sure it's robust, but also proportionate. The plan is that once complete, we will report back to the CCGs with the outcome and the proposals, and to ask you to make a final decision as to whether you want to participate in an East-wide approach. We will be sharing our engagement plans with the CCGs and Healthwatch, and to ask for their feedback, and also to work with all our systems throughout the engagement process. But obviously in doing this, we need to ensure that the methodology is consistent. That's been part of the challenge that we've been discussing recently. In addition to the commissioning paper, you've also got a very brief paper, which just gives you a very high level summary of the activity for 1920. Apologies we couldn't produce a more detailed paper at this stage. Our resources are a bit limited, as you can imagine, due to the COVID response, but we're happy to prepare a much more detailed breakdown for the committee, broken down by languages and locality, if that's what you'd like us to do. I think that's all I want to say at the moment. I'm happy to take any questions.
Tracy?
Hello, yes, I just have a couple of questions. So it's just one is, will this include interpretation and translation in respect of deaf as well, yes, people? It does, okay. And clearly across the whole of the region, kind of needs will be quite different. So I guess our needs in Norfolk will be quite different to other patches. So I hope that those variations will be taken into consideration. And also, absolutely, we need to understand that the stakeholder, patients' experience, public experience of using those currently and what that means, and some of the probably shortfalls of what we might have now and what would be a better service going forward. But it's also, as kind of a user of these services myself in my own consultations, I think that kind of primary care engagement, those dentist engagement, and what works for us the best, certainly in line of some of the new technology and video consultations and all of those things, some of that's been quite challenging over the past few weeks. So I hope that will all be taken into consideration as well.
Yes, Tracy, I'm very happy to answer that. So the engagement plan is very much focused on the patients, but both talking to patients who have used the service, but also to patients who may not have used the service, who perhaps and we need to answer the reasons why they haven't used the service. And some of them may be cultural, in that they are using family members. Some of them may be for other reasons. So we're trying to cover both those. And in terms of the engagement with the contractors, we definitely want their feedback of their experience over the past 3 months. We have seen activity go down across the board, and that is worrying. When we're just about to remind contractors actually that interpreting services are still there, and actually DA languages did accommodate the use of technology, so we need to remind them of that. The other thing, of course, I forgot to mention actually, is that we are planning to extend the service to include pharmacies and optons. So we need to understand what their need is. To date, where we've put in place ad hoc requirements for them, it's been very much for the deaf community, but we need to understand whether it's further than that. And in terms of, yes, the deaf community engagement, we've asked for a separate proposal to be put together that's very specifically targeted at that group.
Thank you. Hein, I think, did you have a question?
Yeah, the question I had is, I think Tracy touched upon it, but I hope we also see the positive side of technology enablement over the last. So I see that the demand for services has come down, but maybe you can have a slightly more positive discussion, because I know we've seen in the past certain surgeries have a much higher use of face-to-face than others. Maybe the possibility of use of technology is more widely accepted now. I had a specific question about this new framework, which ESPO, it's not clear how much of a surprise that can throw into the process to me. Do you have a better understanding of what that might yield?
So the framework that's being published this month is a different framework to the one we're using. We don't have a huge amount of information until it's actually published, which is one of the challenges at the moment. But it's also been confirmed this week that the framework that we're currently using, which is the Crown Commercial Services Framework, will actually be published in April next year, which means if we have a contract extension, we will then have a choice of frameworks to use. And what the framework does is all the quality and financial elements are already evaluated before we draw down, but then we can localize the specification in accordance with need. So there is flexibility to do that. That answers your question.
Okay. Yeah, thanks.
Thanks, Alex.
Hi. Yeah, it's just to get reassurance that you will involve Healthwatch. I know you said you had, but we've got, as you know, Fiona, very good contacts with a lot of the hard-to-reach groups across Norfolk. And I'm sure that Kerry has in Waveney as well.
Yes, we'll definitely be speaking to Healthwatch and the CCGs. We had hoped to speak to you all this morning, and then we realised actually our plans weren't quite as finalised as they need to be before presenting them to you. So,
may I just ask, within relation to the framework, you're saying there's the potential of option A or option B ultimately. How will that finally be selected, and will patients and carers be involved in that process?
We plan to ask a patient representation to be on the evaluation process for that. In terms of choosing the model, we need to look at what they both provide, what the services are, and that's kind of what's going to determine which framework we pick. That's more of a commissioner decision. Once we've selected the framework, then potentially certainly to have a patient representation on the evaluation panel.
Okay, thank you.
Kerry?
Does this stretch across digital as well? So we've been looking at a lot of GP websites at the moment, and some GP websites have got like things that you can click on to get interpretation. So I just wondered if this covers the digital side, because I know that a lot of people have been reverting to Google Translate, which unfortunately doesn't always hold up very well. So just wondered if it was covering that as well.
Yes, it is. So during COVID, the provider in Norfolk, Suffolk and Cambridgeshire did roll out video technology to practices who wanted to use it. It was actually used in Suffolk, and it was used in Norfolk by the People from Abroad team. We need to understand their experience of using that, but absolutely it's a fundamental part now of how practices are going to work, and we need to ensure that whatever solution we put in place works and is appropriate.
Yes, I mean actually on the websites that might be different to the video thing. Do you understand what I was referring to?
I see what you mean.
On a website page, sometimes you'll get a click that you can do, which will then bring up different languages that people can then click on to see the main documents. I just wondered if it covered that for websites, because footfall is dominantly used across CCG, isn't it? So I just wondered if it covered that.
I think we're going to have to look at it now because, and that's partly because with the rollout of remote triage and online consultations, patients are going to be more actively going to the web page. So it is definitely something we're going to have to look at, whether it's within our remit, obviously that we'll have to look at, but yes, it's part and parcel of the engagement with stakeholders.
Any other questions? Great. Can I just ask the Emma, Hein and Kathy, are you happy to go with east-wide procurement appraisal options as set out in the paper?
Yeah.
Yep. Great. So that's approved. Thank you very much.
Thank you.
Moving on to the general practice response. I just thought it might be useful, I asked Sadie to sort of provide a kind of a brief summary of life of the last 3 months, just so that we have some ideas of what's been happening, and I hope that this is going to be useful. Over to you, Sadie.
Thank you, Doris. If people don't mind, because of when I'm sharing my screen, I can't actually see if anybody's raising their hands. So perhaps we can wait until the end for questions, if people don't mind. So just wanted to give you a quick overview of how life has been in general practice and how the CCG has been supporting that during the pandemic. So, I mean, obviously, as Mark has already referenced, we delivered a huge amount of transformation in general practice in a very short time, and practices have made significant changes to the way they work. Every single one of our 105 practices has implemented a total triage model for the delivery of care. Obviously they've had their own impact, from staff having to self-isolate, from staff being shielded or vulnerable, and also they've had to put in place very different methods of consultation with patients who need to be seen. From a CCG point of view, we have reorganised ourselves into a primary care cell. And as Mark has said, that he has led that. So been a number of immediate ways of working that we've put into place. So immediately practices began to zone how they saw patients. So in some areas, so-called hot sites or yellow sites were set up for treating patients with COVID symptoms. And within more isolated practices, practices had to zone their own buildings and put adjustments into place so that they could safely treat patients who needed to be seen. We've had, we established very quickly a primary care incident response function within the CCG, which initially ran from 8 AM to 8 PM every day that general practice was open, in order to deal with the huge amount of queries that were coming through to the CCG, and for us to be able to provide that really quick response to practices to help them. A lot of the early questions were around deep cleaning and practices having to close because a lot of patients were actually turning up with COVID-like symptoms. And we continue to run that desk now, and we send out frequently asked questions. Initially it was daily, and now 3 times a week to all our practices. Practices also supported the rapid discharge of patients from hospitals into specially commissioned community beds. So this table just sets out the arrangements for hot sites in each of the localities. We will share these slides with you after the meeting, but it just shows that you know, there were different arrangements in place to suit the needs of patients and the infrastructure within each of the localities. Practices, I mean, their support has been quite incredible actually, and certainly over Easter and the early May Day bank holiday, all practices opened for normal business. and there was a contractual change nationally to their contracts in order for them to do so. Unfortunately, because of the progress of the response to the pandemic, that wasn't required from practices when we got to the late May Day bank holiday. We also know there were many reports nationally around the challenges in obtaining PPE across the country. In fact, what we did in Norfolk and Waveney was formed a PPE cell to support general practice and other providers, and we've redeployed CCG staff into that. And practices submit a weekly return on their stock levels, and we have volunteers from the community delivering PPE on a weekly basis to practices, and I know that that has been very well received. Of course, practices have also had to change the way they work, as I mentioned earlier. So, remote working of staff, video consulting from home, for example, changes within the back office function to enable social distancing, and of course, undertaking risk assessments for their staff, particularly those from Black and minority ethnic backgrounds, who we know there is a disproportionate impact on health from national evidence. And we've mentioned technology already. Actually, these numbers are a little bit out of date now. It's better still. We have about 85 practices now out of 105 who have an online consultation system working, and a further 5 or 6 practices in train. We've provided hundreds of webcams and headsets and additional laptops, and our digital team has managed to deliver a huge piece of work in a relatively short period of time, and we continue to try to procure further hardware to support practices. Another great innovation in Norfolk and Waveney has been the implementation of our COVID Protect system across most of our practices. And that has enabled the support of patients who are shielding or very vulnerable to COVID. And a large team of CCG staff, again, have been redeployed to support that implementation and to support practices in checking in on their vulnerable patients. In terms of our phase 2 response, which we're now in, we've switched to supporting business continuity planning, helping practices make sure that they're responding to the nationally published standard operating procedure, responding to the national implementation of test and trace, which of course could have an impact on practices' own business continuity if they lose staff as a result of that programme. We've also been given a huge amount of support on infection prevention and control, and we're working up a programme of webinar-based training for staff in donning and doffing, PPE, refresher, training, cleaning, waste disposal, and so on. And with the more recent hospital guidance for non-clinical staff, we've also provided that same level of support to practices, so that where they are unable to socially distance their non-clinical staff, we have provided additional fluid-resistant masks, and we're putting on training for non-clinical staff in how to safely wear that PPE. A great success story for us in Norfolk and Waveney has been the commissioning of our first Norfolk and Waveney system-wide locally commissioned service around care homes, building on what was already in place in 2 or 3 of our CCGs. So now we have 104 out of 105 practices that have signed up to that, but the remaining practice doesn't have any care home patients. And now practices are building up their plans to weekly check in with their aligned care homes. We're aligning those care homes that are currently served by a number of practices, making sure that there's clinical pharmacist input to care homes, and that we are jointly with community services developing care and support plans for residents. And we've also put in place medical support arrangements for community discharge beds. In terms of moving into the next phase, we obviously know that COVID is going to be with us for some time to come, and we need to support practices return to normal levels of activity going forward, whatever that might look like, increasingly through a digital approach. And we know that practices will have to respond to that in very different ways, given that there will still be staff needing to work remotely. And of course, there's a lot of catch-up work to do for practices as well, in terms of long-term condition management, screening and immunisations and health checks, for example, which had to be paused in the early stages of the response in many cases. Obviously, primary care network development is still very much a key consideration for practices, and they are stepping up their recruitment plans to fill their additional roles that they have funding for this year. We really need to support general practice with their capacity and demand forecasting, and looking at estates in the new normal, for example, but also thinking about how the pause in secondary care and the waiting lists that have grown in secondary care will impact on general practice as well. So we're continuing to focus on all of this through the primary care cell. We continue to remain very agile, as do practices, in response to situations and guidance that comes down nationally. And we are working to continue to develop close links with health and social care organisations so that we can continue to develop an integrated multidisciplinary approach as we go forward. That's the end of the presentation, so I'm just going to attempt to stop sharing so that I can see if there are any questions. Sorry.
Tracy?
Hold on, just get my mute off. Yeah, I just want to say, really, kind of on behalf of primary care, being one of those involved in all of these transformational changes and things that have been happening over the past few weeks, a huge thank you to, you know, Sadie, Mark, Kath, Parveen, and particularly the PCN associate directors who've really worked collaboratively with primary care to kind of support us through this, because it's been a real kind of partnership approach. So just some acknowledgement and some sincere thanks for that, which I know my colleagues in primary care all feel. For me, the next, we're in phase 2, but phase 3, I think I'm concerned about the resilience of primary care. It has been a, you know, it's been challenging, and kind of that resilience going forwards when you know, more patients will be accessing services again, rightly so. We've got new means of people accessing our services, such as footfall. So it's just that demand and that capacity and the resilience, really. So I think that will be a challenge going forwards.
Thank you, Tracy.
Alex?
Thank you. I am unmuted, aren't I?
Yeah.
I guess one of the things, it links partly to what Tracy's just said. I suppose, have we got any sort of plans in place for dealing with people who may have either had stroke or heart attacks during this period and not presented? Because I think that they're going to be a massive burden back on both community and primary care as we move forward, when we start to sort of unveil, as it were. So
Thank you, Alex. I might look to my clinical colleague, Kath.
That's a good technique, Sadie. Well done. This is just my opinion. but I was on a call today, a national call, and one of the concerns that we have nationally is people who have chosen not to present to any form of health care setting. And I think whereas the strokes and the heart attacks, yes, obviously there may be those sort of patients out there that haven't presented, and we're going to need to look to how we would support them. I'm thinking it's more deterioration of long-term conditions and symptoms of suspected cancers, and things that are, conditions where they may have been on a waiting list for a routine operation, but the delays have considerably worsened their health and the symptoms. And I think that's the area of concern that we're going to have, and I think we're going to see this for a long time. Plus the screening programs that have been suspended, and also people would have had routine referrals into the acute settings, and we know that there would be a rate of diagnosis of cancers through routine referrals as well. So I don't think this is specifically to Norfolk and Waveney. This very much, I think, is a national issue where we're going to see non-COVID consequences to the COVID pandemic for quite a while going forward. And I would be lying if I thought we have got a robust plan at this moment in time, but that's part of our reset and restoration planning, is to consider that sort of demand.
Hi, Mark.
Hi, thank you. I completely agree with what's been said. And just in case it's helpful, just to give a practical example of what we are doing and not just thinking about doing. This morning, there was a meeting between some of John's team, John Webster's team, and my team, and the Norfolk and Norwich. And we are really, what's so encouraging is that we clinicians at the Acute Trust are very keen to work with primary care colleagues to say, how do we collectively best support individuals who've been affected in the way, or may have been affected in the way you describe, Alex. So I think it's linked to the capacity challenges. It's absolutely right and important that we maximise the capacity that we do have and that will be stretched going forward. And I've been really encouraged this morning, and we're looking to meet again next week to start to say what are our clear objectives going through this phase, how are we going to do this, who's going to do it, to really firm up that plan. So that work is absolutely in train, Alex, but it's a really important piece as you raised. Thanks.
May I just come back? Because one of the things I think we need to somehow successfully do, and we would be very willing to help here, is market what you're saying, because I think people will understand it and all the reasons why. But I think if we don't sort of voice our opinions and concerns, it could be lost and people will soon forget.
Thank you, absolutely, and thank you for the offer. And I think that's going to be a really important part of it, Alex. So it'd be good to speak in the next week or so if you have some time, please.
Kathy?
I think just to add, I think it's letting people know it's safe to come back as well, because a lot of people are still very scared to come to our healthcare settings, and they, what's on in the media. So that's really important to say it's safe for you to come back, to have your cervical smear done, your screening test done. That's a really important message. Any help with that would be greatly appreciated.
Yeah. So my comment was, first of all, to echo what Tracy said about the enormous amount of work that's been done, and to pay tribute to that. I think certainly for myself, caring for two extremely elderly, frail, shielded parents, things like footfall are just completely marvellous. And actually, I think that hopefully it signals a way that people can change their behaviour. And so kind of to emphasise Alex's point, really, which is marketing, that, we need to behave differently in relation to primary care in order to kind of protect the resilience of it. The point I wanted to make was particularly about workforce. Well, you called it workforce planning in your slide deck, Sadie. And I wonder if we could move to kind of starting to call it workforce development, because the thing that's always concerned me about primary care workforce is they've tended to take it from somewhere else. And we know that, workforce is stretched across the piece. And I wonder whether with the new architecture, we could think more about growing our own in-house and actually growing for the system as well. So so that was something that I hopefully we can look at in the future.
Thanks, Kathy. That's a really good point. And I think, there were early reports nationally as a result of the response to the NHS and key workers, that actually there was an increase in interest in joining the NHS and training for roles, and I think we need to capitalise on that, absolutely.
Any other questions? Great. Thank you very much, Sadie, actually for all the work you've done. I mean, I know I'm a bit flippant sometimes, that, you know, you obviously be sitting around drinking coffee and not doing any work. It's obviously not true. But thank you, you know, working with all your colleagues to support the system. On to any other business. Has anybody got any other business? No? Excellent. So thank you all very much for your time. My goodness, I'm only 2 minutes over part one. So especially thank you to Alex and Kerry for joining us. And we will see you again in July, hopefully. And for everybody else, before we move on to part two, do you want a 5-minute stretching of legs? Or are you happy to carry on and incentivize me to get moving because the drinks are waiting?